Good evening, and welcome to part 2 of Methodist Healthcare System series overview of colorectal cancer, and it's in recognition of Colon Cancer Awareness Month. Part 1 we did on Monday, talking with specialists, discussing with patients over importance of open dialogue with their physicians, the importance of screening, the importance of who needs to be screened, when you need to be screened, and then also going through the procedure of a colonoscopy. Tonight, we'll be focusing on what happens when someone has been diagnosed with colorectal cancer. This evening, I have 3 specialists with me. Dr. Hanni Salih, hematologist, medical oncologist, Dr. Steve Abbate, general surgeon, surgical oncology, and Dr. Joseph Karam, general surgeon. Tonight, it is an open forum and discussion, and we welcome your questions through Facebook, so feel free to comment. This is intended for discussion and not for medical advice or treatment diagnosis. So at this time, while we're waiting for our participants to log into Facebook and ask our questions, would you mind, gentlemen, Dr. Salih, starting with you, giving a brief introduction of your background, credentials, and special interests?
Sure. I'm Dr. Hanni Salih. I'm a medical hematologist oncologist. I'm in private practice here in San Antonio, Texas. I see a wide array of disorders that includes anything from benign hematology to solid tumors, cancers such as lung cancer, colon cancer, rectal cancer, and such.
Dr. Abbate?
Hi, my name is Dr. Steve Abbate. I'm a surgeon and I work in a multi-specialty oncology group here in San Antonio in private practice. My practice covers a spectrum of benign general surgery, but also includes a significant component of surgical oncology, including breast oncology, gastrointestinal oncology, and pancreatic surgery.
I'm Joseph Karam. Steve and I are in the same clinic. We're a multi-specialty group. I'm a general surgeon born and raised San Antonio. I've taken a special interest in minimally invasive surgery, a lot of robotics. I do a large amount of benign surgery, but a fair amount of malignancy as well. Thyroid and breast, of course, and then colon cancer, gallbladders, hernias, paraesophageal disease, and ventral hernias.
Thank you, gentlemen. So to start tonight, I'd like to go over the differences when someone is diagnosed with colorectal cancer, and what is the subset of those cancers. Maybe each one of you could take an opportunity to explain that.
Sure. So when we say colorectal cancer, this is essentially an umbrella term. You have colon cancer and rectal cancer. And the difference between the two essentially boils down to the location within the colon itself. The way we approach treatment of these malignancies depends on a number of factors that we'll probably get into as we discuss, which includes everything from stage, location, patient comorbidities. A number of factors are taken into account as we move forward with management of colorectal cancers.
So when you're talking about colorectal cancers, can you talk about the different options, Dr. Abbate, for the colorectal cancer treatment, maybe starting from they walked into your office to the process of going through that treatment?
Sure. So when you look at people when they have a new diagnosis of cancer, we evaluate and treat people in a stepwise approach. So the first challenge is to make the diagnosis, and once the diagnosis is made, then the next step is to do what's referred to as a staging evaluation. And this is something that people may or may not be familiar with, but the purpose of a staging evaluation is really to determine the extent of the cancer at the time of diagnosis, because the stage of the cancer will influence the treatment options that the patient receives and the treatments that you recommend for folks. When you look at the treatment for colon cancer, and this is in different than what Dr. Salih had pointed out, rectal cancer, because the treatments do vary a little bit. But when you look at the treatments for colon cancer, those are largely limited to surgery to remove the segment of the colon where the cancer is, And then in selected patients, based on the extent of their disease, they may require chemotherapy after surgery. Whereas for rectal cancer, which is not typically the focus of today's discussion, radiation is also used in the treatment algorithm for those patients, and they're more likely to require chemotherapy if they have a tumor in the rectum.
Dr. Karam, why would someone need surgery versus, and Dr. Sleeve, jump in at any time, versus just having chemotherapy?
The goal for surgery, of course, is to completely remove the malignancy. Dr. Preop alluded yesterday, screening is most important. Occasionally, screening colonoscopies will find a cancer. If it's small enough, it can be removed with just a little snare polypectomy. Then oftentimes that's curative. But when the lesion becomes larger, if there's concern that it's invaded lymph nodes, or occasionally it just cannot be removed through colonoscopy, then generally you're moving towards surgery. And the goal of surgery is what's called an R0 resection, which is complete removal of the lesion. So there's plenty of colon to spare. If the recommendations are to obtain between 2 and 5 centimeter margins on each side of the lesion. So if there's, the lesion is one location, you want to remove colon on the healthy colon to each side, and the idea is to remove everything. So colon cancer is usually surgery is the first approach.
And before we move on, just to expand on that, one of the other objectives of surgery, there are really two objectives. One is to remove the tumor, as Dr. Karam alluded to, but the other is to make sure that you're doing an adequate lymph node removal. So when lymph nodes, what lymph nodes are, they're filters. They kind of filter all of the organs, the blood supply to the organs, and the lymph nodes travel along with the blood supply to the colon. So an important component of a colon cancer operation is to make sure that you're removing the blood supply to that segment of the colon so that you can remove the lymph nodes that are at risk for involvement. And one of the kind of standards that we use as a quality metric for the adequacy of resection is the number of lymph nodes that are removed, with a goal for colon cancer to have at least 12 lymph nodes within the specimen.
That was my leading question, is like, what are the percentages of getting everything through that? Okay.
There are times when surgery is not an option, and the times where surgery is not an option is when you have what they call distant metastatic disease at the time of diagnosis. So if the cancer has spread to other organs or beyond the colon itself, surgery up front may not be an option. If there's a small amount of disease that's outside of the colon, you can actually start with chemotherapy with the hopes of being able to remove distant areas of disease later on down the line.
So, of course, it's going to be patient dependent, but how long would a typical surgery last? And maybe you can talk about open versus minimally invasive.
Open approach was definitely the most common approach, and in some regards it still is. Laparoscopic robotic approaches are becoming much more prominent. Steve and I both do robotic surgery very frequently. It's the majority of what we do. An open colon operation is definitely a faster operation, but the incision's larger, the recovery's longer. Robotic approach usually takes a little bit longer, not a significant amount of time, but it's a little longer approach. But with depending on a right side hemicolectomy or a left-sided colon resection, the operation on average maybe around an hour to an hour and a half. Complicated cases, they can be longer. We've battled through some tough ones that are maybe three hours or even 4. But we try for more minimally invasive approaches because it benefits the patient in the long run. So smaller incisions, the recovery time's faster. Something that we've been working on in our clinic has been ERAS. So it's an enhanced recovery after surgery.
Right.
So that lends itself towards faster recovery, and it's generally for laparoscopic cases. Now, we will make the effort to do a more involved operation, a more complicated operation robotically, so that patients can potentially go home in post-op day 2 on average. And sometimes it's less than that, but I'm most comfortable with 2 days.
This one, that's still remarkable. So within the surgery, is it necessary to remove a portion of the colon? Maybe if you briefly touched on rectal cancer as well. Does that need to be removed? Does that happen often? Can you talk a little bit about when there's a removal?
Sure. So when you have a treatment for colon cancer and for rectal cancer, often for early stage disease, the initial treatment is frequently surgery. And with regard to the extent of surgery, that has really influenced a variety of factors. Number one, the location of where the tumor is. So depending on the location of the tumor, that may kind of have influenced the volume or length of colon that needs to be removed. And then the other factor that influences the extent of resection is the blood supply to that segment of the colon, because you need to make sure that in order for the reconstruction that you do after the cancer's been removed, the ends of the intestine need to have excellent perfusion in order for that to heal properly. So if there are certain locations of the colon where the blood supply dictates that you need to do a more extended resection, whereas in other locations you can do a more limited resection.
Understood. If a patient is going into surgery, and you alluded to this a little bit, specifically with minimally invasive, but what does that typically look like for a patient, just to prepare them for that surgical experience?
Pre-op, there are a number of things we'll do pre-op, and Dr. Salih can talk a little bit about the patients when we're dealing with any chemotherapy prior to. One thing we'll want, of course, is they'll have a CT scan that's going to screen to make sure there's nothing that's metastatic, like Steve was talking about. We'll check CEA levels to have a baseline before we remove anything. But outside of the clinical pre-op, it's a patient that we want to make sure that their heart and lungs are healthy. They'll be able to tolerate general anesthetic. Prior to the operation, we want to make sure that they've held all their anticoagulation, appropriate surgical candidate, and their bleeding risk is normal. Before that, we'll do colon preps. And the literature's changed a little bit back and forth about whether or not antibiotics is necessary for that. It's still a little controversial. I've gone back to using antibiotic and bowel prep. And kind of, again, going back to the ERAS protocol, there are a couple of high carbohydrate drinks, Celebrex, Tylenol, and gabapentin. There are a few medications that we try to give a few hours before and the night before the operation that kind of prepare them for the operation that they're going to undergo.
So you've gone through surgery, and what would someone expect after surgery? Recovery? Then they come back to whether they need continued follow-up for chemotherapy as well? Maybe a joint question.
From my perspective, from the perspective of the oncologist, that's correct. So post-operatively, they need some time to fully heal before we can begin chemotherapy. But there's a long process in the sense that once you finish the surgery, you need to really have good education as to what's happening and what's going to happen with the chemotherapy. Oftentimes, particularly with these GI malignancies, we put something called a chemoport under the skin in order to be able to give the chemotherapy. And they can talk a little bit about placing the chemoports. They do that frequently, but that's something that is pretty safe that we can put in, and it allows us to be able to do the chemotherapy, because the chemotherapy itself is actually an infusion, and you'll go home with it for a couple of days frequently. But ultimately, after the surgery, what needs to happen is adequate time to heal. And once the patient is fully healed, we sit down with the patient, start educating in terms of what's going to come with chemotherapy, and can proceed from then on.
Perfect. And that also correlates probably to the stages, right?
Mm-hmm.
Correct?
Mm-hmm.
Of
So
the cancer.
not every patient that has surgery necessarily needs chemotherapy. So early stage, very small malignancies, you may be able to do surgery and follow with observation. But if there's lymph node involvement, and if there are people that have specific factors that we don't necessarily need to get into, they would benefit from having chemotherapy afterwards.
Great. Dr. Karam, this maybe when you talk about robotic surgery, the question came across about how big is the scar, or will it be?
On average, we try to do the same way every time. I think that's usually a pretty good practice. The the incision is going to be as small as you need to take the specimen out. So the entire operation, and like I said, Steve and I do the same procedure. The entire operation, it's the division of the blood supply, ligating or cutting the two ends of the colon that you're going to remove, and then bringing the two ends back together. We do all that inside the abdomen. That's called an intracorporeal anastomosis. So all that's done through technically 4 incisions that are 8 millimeters in size. There's one incision that's a little larger. It's a stapler. It's 1.2 centimeters. But we can do the entire operation through those 4 incisions. If we didn't have to take the specimen out, that would be it. We wouldn't need to do anything larger than that. To remove the specimen, what I found, and this has been painstaking, you can ask anyone in the operating room with us, we try to keep that incision as small as possible. It's just my own preference, I guess, but 4 centimeters is the incision that we are usually able to keep that to. So the incision will kind of work its way out through a 4 centimeter incision on the abdominal wall. And that would be, in most cases, that's a left colon resection or right colon resection. We're able to use that about the same. Steve, what do you think?
Yeah, I would agree. Probably on average a 4 to 5 centimeter incision for specimen extraction. Obviously, a larger tumor necessitates a larger incision.
Right. So that obviously gives a quicker recovery, if you will, with not having such an open scar.
Yeah, fewer complications also after the operation. Recovery is one. I mean, despite pain, we'll get patients over the operation, but hernia risk, a smaller incision is always less likely to result in a hernia. And do a fair amount of hernia surgery as well, so it's always nice to have fewer hernias out there.
Perfect. Another question that came in, how will my diet and lifestyle change after surgery or recovery? Does it change?
So from a diet standpoint, when you really look at the function of the colon in essence functions like a large sponge. So most of the digestion of the food occurs within the small intestine before it reaches the colon. And then about 1 gallon a day of waste material gets delivered to the colon, and as it travels through the colon, the water gets absorbed and the waste becomes more solid. So when you remove a segment of the colon, you're not changing the body's ability to absorb nutrients overall. If you remove a large segment of your colon, you could notice a change in the frequency of your bowel movements. And even that tends to be a little bit of a temporary phenomenon, and then the body adjusts. So most people after a colon resection, once their body has recovered from the surgery and adapted, they can go back to essentially a normal lifestyle, and there's no long-term dietary restrictions.
So it does bring up a point, and people are going to ask this, and another thing about it, colostomy bags. When is that effective? Like, when is that necessary, if it at all?
Pretty rare with what we do. It's for colon surgery, which is going to be inside the abdomen, again, excluding rectal operations. The plan A is rarely an ostomy. Occasionally, if we wait too long, if the colon cancer is obstructing, then sometimes that's necessary, but generally the plan is to reestablish continuity, and by that I mean sew the two ends back together so it's a normal bowel function afterwards. In cases where it's a very low-lying colon cancer, sometimes an APR, it's an abdominal peritoneal resection, is necessary, and that one, the only outcome really is an ostomy. Okay. And that's pretty uncommon, though, with what we do.
In the other time that a colostomy is utilized, if after the initial operation, if that connection you make for the reconstruction of the colon, if that doesn't heal properly, then some patients require a second surgery to create a colostomy to allow for proper healing. That's an unfortunate complication, and it's an unfortunate occurrence. And the rate in which that occurs varies based on the type of colon, the segment of the colon that you remove, but it averages anywhere from less than 5% to about 10% risk. So unfortunately, that is one of the inherent risks with any colon surgery, whether it's for cancer or benign disease. There is a risk, a very real, genuine risk of needing a colostomy.
Okay, thank you. This question has actually been posted a couple times, so I would like to get into discussion about this. And Dr. Salih, this may be something you can address along with your colleagues. Can you please discuss treatment with immunotherapy?
Absolutely. So immunotherapy is a hot topic right now in the field of oncology in general. We're finding a lot of different uses for immunotherapy in multiple types of cancer. In colon cancer specifically, immunotherapy has come into play and I've used this word previously, in the metastatic setting, which means when the cancer is spread from the colon to other organs. Now, traditionally, in this setting, we start with chemotherapy first because it affects the widest range of patients. But immunotherapy has worked its way into treatment after they've progressed after the first line of treatment. Now, the way it works is kind of like this. It's using the immune system of the body to target the cancer cells. Specifically, they use drugs in colon cancer that are called checkpoint inhibitors. And what they do is they block the proteins that hide the cancer from the immune system. So in theory, you're able to allow the immune system to attack the cancer cells. And they've shown some benefit in that particular setting that I've mentioned previously. There are ongoing studies now to see if we can use it earlier in treatment in colon cancer. But specifically in colon and in rectal cancer, that's where we are in terms of the immunotherapy.
Great, thank you. This also came as a question that came through. If I'm having a hard time with my diagnosis, and of course that depending on any stage, are there any mental health resources that you offer, or you possibly know of, or you talk to your particular patients about?
Absolutely. Anytime you get a diagnosis like this, small or large, it oftentimes can be life-changing. And it can be difficult to cope with, which is very understandable. In my experience, we've had a lot of success with support groups, actually, and we've been able to send patients to cancer-type specific support groups where they can talk to people that have shared similar experiences, how they've been able to cope and manage through the process of treatment, and I've had a lot of success in this manner.
Great. Any other thoughts on support groups or within your group?
No, I think in addition to that, there are other resources that are available. A lot of communities and hospital systems and practices have the availability of nurse navigators. Mm-hmm. Nurse navigators are nurses that are specifically trained for assisting patients with a cancer diagnosis. Oftentimes, they're trained in a specific type of cancer, so they're very, very knowledgeable on that particular disease, so they can be an excellent source of resources for the patients for education, emotional support, guidance, and so they prove to be very, very valuable resource for the patients.
I know that as a Methodist healthcare system, that we do have access to our navigators, and we can offer that information on our page, and it covers not only just for colorectal, but it covers other areas of cancer. So it's very important to have that opportunity and that discussion. Any other just questions coming in, and as we're waiting for those, and I can start with Dr. Salih, just tell me a little bit about your journey and why you chose this area, oncology, and specifically
Sure.
for complex GI.
Yeah, so I have a little bit of a unique background. So I actually started off in college in computer science and did a lot of programming and found my way to a subject called bioinformatics, which was a lot of genomics type work and genetics work, and I found the science very interesting. A lot of the science coming from the field was coming from oncology. And I think this was a primary driving factor for me to even go into medicine. And I've just pursued it all the way through, and that's kind of how I ended up in the field.
Glad you're here. We did have another question come in before I move to Dr. Abbate. I think we addressed this, but one more time, can you tell us a little bit more about the actual recovery time after colon surgery?
So if you were to look at, the operation, if you have the surgery that's done on a particular day, that operation can take anywhere from an hour and a half or longer to do. People then are admitted to the hospital in an inpatient setting. An average hospital stay for a colon resection can vary anywhere from kind of 2 to 5 day range depending on the approach of the operation. Minimally invasive surgery, whether it's robotics or laparoscopic surgery, typically on average 2 to 3 days. For a open colon operation, the typical length of stay is 1 to 2 days longer than with a minimally invasive operation.
And then going back to your regular lifestyle,
Right.
obviously depends on the patient and
And then, exactly, and then following discharge, and again, this will vary person to person based on their age, their physical performance status, their other health issues, but it could be anywhere from 2 weeks to 4 weeks till they get back to most of their regular activities. And then oftentimes people will have some limitations to more strenuous activity for several weeks after the operation.
great. We're waiting for another question. Would you tell us a little bit about your journey to this specific area?
Sure,
Dr.
sure.
Abbate?
So, when I went into medical school, I had a whole range of ideas of what I might want to do for a specialty, but then it became very obvious to me during my third year clinical rotations that I wanted to do surgery. I liked gastrointestinal diseases, and I liked the physiology associated with the gastrointestinal system, the endocrine system, so that led me to the general surgery specialty. With regard to my current practice, I do have a large emphasis of oncology in my practice, and I find that very, challenging and also very rewarding work. Oncology is a very rapidly developing field, so I think it's stimulating from an intellectual standpoint. I find the work, the cases can be rewarding and challenging, but it's also very meaningful work because it's impactful to patients that are often going through some of the most difficult times of their lives.
I know. Thank you. Dr. Karam, a little bit about your journey.
My plan A, this is actually plan B. I wanted to be a superhero. It was really unfortunate. I couldn't fly, and the superpowers never really developed. But I had always worked with my hands, so when I was growing up, I did what I could to take my mother's car apart, the interior. And I used to take random things apart around the house, the VCR. But as went through college, I just kind of realized I needed to do something that was, coordinated, hand-eye coordination, creating, sometimes disassembling. But I kind of had a propensity to just want to help people through a tough time, just like what Steve said, until somebody's, cried in your office out of fear and then just embraced you and hugged you and cried tears of joy when everything's okay. It impacts you in a really wonderful way. So it just inspires you to keep doing that.
Sorry, go ahead. No, go ahead.
When I was in residency, I knew I was going to want to do surgery. I just didn't know what type. But when I was in residency, I had some very wonderful attendings, influential, fantastic at what they did. And it was really kind of hard to choose. So I didn't want to go into any kind of subspecialty. One of the wonderful things about what we do is, it might be a thyroid neck operation one day, it's a colon operation the day after that, and it's a lipoma on the back of the leg after that. So it's variable, and it keeps things very interesting.
We did have a comment from our Facebook page, and it said, from Taj, Dr. Karam and Dr. Abbate are great physicians who always put their patients first. So you're doing a good job. I know Dr. Salih just joined the practice, but we'll get these comments. You will.
Fantastic.
Any other questions or comments I do have one more. So before surgery, should I avoid certain foods?
Not particularly. With the ERAS diet, we recommend clear liquid diet maybe the day before, and even up to 2 hours before the operation, minimal amounts of clear liquids. But the only real complication is you want to have basically a bowel prep, a clean colon as much as possible. In the operation, we're opening up 2 segments of the colon, and we're exposing the inside of the abdomen to the highest bacterial burden in the body, which is the colon. So you want that to be as I think pristine's the word, as pristine as an environment as possible, but clean is really what you're looking for to prevent intra-abdominal infections. Other than that, no, I don't feel
Any
no
restrictions?
No.
And they do some pre-admission testing, obviously to prepare for the surgery as we discussed, but no other restrictions at that point. Another question? Hold on one second. So another one is, can you discuss complicated and technical procedures in a way patients can understand? I might need a little bit of clarification, but maybe with the robotics or open surgeries, can you kind of narrow that down in a...
Sure. So when you look at the approaches to surgery, open surgery is what's defined as making a single large incision through the muscles of the abdominal wall to gain access to the abdomen so you can remove that segment of the colon. That's how surgery was initially developed. That's how it was done for centuries up until the late 1980s. In the late 1980s, they developed initially in Germany the technology to do laparoscopic surgery. And so what laparoscopic surgery is rather than making a single large incision through the muscles of the abdominal wall, you make multiple small incisions and work through ports. And you can insert instruments and a camera through these ports to perform the operation. And then more recently, an advancement on laparoscopy was the development of robotic surgery. Now, during laparoscopic surgery, the surgeon will actually be at the patient's bedside manually controlling the instruments, and an assistant will be controlling the camera. So where robotic surgery differs from laparoscopic surgery, the instrumentation is similar, except for the arms of the robot are actually controlling the instruments and the camera, and the surgeon is controlling the arms remotely from a console. And the reason why robotics is kind of an advancement on laparoscopy is some of the technology is improved in terms of enhanced visualization, improved instrumentation that allows you to do more complicated surgery through a minimally invasive approach that was more challenging to do through the traditional laparoscopy.
Right, it's more common, I suppose.
And that's a common misconception, I think, what Steve was talking about with the robotics. It's not a robot doing the operation. There's not a colon button, a left colon button where you kind of sip coffee and step away from the machine. There's no artificial intelligence chips. There's not a millimeter of movement that takes place without the direction of the surgeon guiding it. So it's still surgeon controlled. It's a surgeon doing the procedure, but it's robotic assisted for steady, holding the camera in a steady fashion, very minute movements. There's no tremor. And then you also have wrists. So it's like doing open surgery with small instruments, but again, there's no artificial intelligence to it.
That makes sense. So I think we see robotic in a different way. Right, correct. As we close, do you have any just closing comments for our participants? Talking about colon cancer, talking about symptoms, anything you would like to say, just kind of a last closing word?
Yeah, I think in general, as I've said before, anytime you get a diagnosis with the C word being cancer, it's jarring and it can be very challenging at first. But I always tell my patients in general, as you go through the process, try your best to read about it, educate. If you have any questions, ask questions all along the way. I frequently tell people to just keep a notebook, and you'll leave the doctor's office and you forget to ask a question, and write it down in the notebook so that when you come back, you'll have it available and can ask, and knowledge is power.
Yeah, I think my closing comments would probably be to even just echo what was talked about 2 nights ago in this forum rather than what we talked about tonight. The importance of people to make sure that they're following the recommendations for colon cancer screening. Colon cancer is one of the few types of cancers that we actually do population-based screening for in the United States. And really, when you look at a cancer that is appropriate for population-based screening, it needs to meet 2 criteria. It needs to be a cancer that affects a large percentage of the population. Otherwise, it wouldn't be effective from a cost perspective to screen for a very rare cancer. And you have to have a good way to screen for that cancer, and ideally with a precursor lesion to the cancer. And we meet all of those criteria with colon cancer because we have the ability to do screening colonoscopies. There are well-defined precursor lesions to colon cancer, specifically colon polyps. And this allows people to, in some cases, avoid the progression to cancer or to have their cancer identified at an earlier stage. Colon cancer, when identified at an early stage, is often cured and often cured with surgery alone. Whereas if it is diagnosed later, it's more difficult to treat and the prognosis isn't as favorable.
Thank you. Dr. Karam?
Yeah, echo that. Doing surveillance for colon cancer, colon screening has proved effective. If you look at the numbers in the past maybe 10 years, 20 years, the cure rate for colon cancer over the age of 50 has increased, meaning we're doing better. We're diagnosing probably a similar amount of colon cancers through colon screening, and we're catching it ahead of time the way we should, because the age is 50 if there's an average risk. Each year, though, diagnoses of patients younger than the age of 40 has gone up each year. So there's something that's a changing environment in Western culture. It's the food, I don't know. But we saw a problem decades ago. I wasn't part of this, but the forefathers of this, the pioneers, they saw a problem earlier and they're catching it now. But something's changing, and now the diagnosis is happening younger and younger. So there will be an adjustment, but the idea is, to echo what Steve said, is you catch this when it's a small malignancy, a small cancer, it's a small problem, and it's an easy fix. The average risk is about 5 to 6% that you'll have a colon cancer in your lifetime, and that will probably change as we continue to evolve, and so does our environment.
Okay, I had one more question come through, gentlemen, and if you can help me with this. What is the difference between an ostomy and an inostomy? What is the point?
Ileostomy.
Yeah.
Ileostomy, thank you. What is the point, and is this permanent?
So the difference, take those questions one at a time. The difference between an ostomy and an ileostomy. So an ostomy is, again, an umbrella term to indicate any time that you intentionally suture the intestines to the skin of the abdominal wall so that it empties into a collection bag. There are different types of ostomies that you can have. If you're suturing the colon to the skin of the abdominal wall, and so it can empty into a collection bag, that's called a colostomy, C-O-L, colostomy. If you're using the small intestine and you're suturing that to the abdominal wall, the segment of the small intestine that is sutured there is typically the ileum, so that's referred to as an ileostomy. So the difference between a colostomy and an ileostomy is simply which segment of intestine is sutured to the abdominal wall. The second part of that question, whether or not it's permanent, that really is a decision that's made on an individual basis. So based on the patient's underlying condition, the reason that you're doing the surgery, the location of the tumor, the type of surgery that you did, that ostomy may be permanent. A majority of ostomies, however, when they're created, have the potential to be reversed.
Oh, really?
Yes.
So you're seeing that often?
Yeah.
Okay.
To kind of add to what Steve's saying, the way that it would also affect the patient, colostomy, like Steve was describing earlier, the colon acts as a sponge. It's going to absorb all the fluid. If you have an ileostomy, the volume is, the output can be very high. In fact, oftentimes you're on medications to try to reduce that volume. You can become dehydrated. Patients with kidney disease can have higher complications with an ileostomy because they're losing a lot of that volume. It's leaving the body before the colon has a chance to reabsorb it. In a colostomy, it's, as Steve described, it's the colon that's exiting, but it's done most of its job. It's reabsorbed, so it's kind of more solid output. It's more of, I guess it's just an abnormal fixture to your abdominal wall, but it's a less of a risk to the patient than the ileostomy on the spectrum of dehydration
Okay.
and nutrients.
Thank you, gentlemen. Another question we had come through, if you find polyps during your colonoscopy, which can happen, does it put you at a greater risk for colon cancer?
Yes. So when you look at the progression from normal colon to colon cancer, it typically, in most patients, it follows a stepwise approach. So colon cancers, like most cancers of the gastrointestinal tract, come from the inner lining of the colon, what's called the mucosa. And if that lining of the colon or the mucosa starts to overgrow locally, that becomes a polyp. Now, most polyps, when they're initially identified, are benign, but if left untreated, over time, a percentage of those polyps could progress to malignancy. So if somebody has a polyp that's found on a colonoscopy, that is something that's considered a precursor lesion to colon cancer. And if somebody has a propensity to form colon polyps, then they do require careful colonoscopy screening, and that interval can be range anywhere from yearly to every 5 years, depending on the size and number of polyps that they have, but they are at increased risk for colon cancer.
Did you have?
And I'm just going to say that I think that it underscores the need for screening and why people should go for screening as directed.
So that was a segue into what we talked about on our segment on Monday, considering the population. But if you have a family member that has been diagnosed, just to kind of follow up with that discussion, when should they be screened?
Yeah, so this comes into play particularly when you have family members that are diagnosed at early age. And if they're diagnosed under the age of 50, and it's a first degree family member, such as a mother, a father, a sister, brother, your screening will come earlier than the traditional screening. And I think typically it's about 10 years prior to the diagnosis of the youngest family member. There are some syndromes, without trying to get too much into the weeds of this, that can be associated with increased risk of colon cancer. And I think this was touched on Monday in the discussion. So if you have multiple family members that have been diagnosed with colon cancer or other malignancies in general, that should be discussed with your doctor.
Thank you. I appreciate it.
One of the last statistics I recall is about 25% of the population have a family member that puts them at elevated risk. Is it, what you're familiar with that statistic? It's a family member that it doesn't put you at high risk, but you're not at the average risk for colon cancer. And 25%, 20 to 25, that's a pretty high number.
Okay. So in summary, it's important for the screening, it's important for the conversation. And colon cancer, sometimes we don't want to talk about it, but the open discussion is important. We do have a Facebook viewer, Justin Whitaker, says hi to Dr. Karam.
Hey.
And thank
Hey,
you.
Justin.
You got your whole fam club.
All right, all right.
So you are a little bit of a superhero there. You're good. So, gentlemen, I am so grateful for your time, and I know everyone who is participating in these series appreciate it. For our participants, if you have additional questions, you will be provided a number at the end of this program, and please feel free to contact that number, and you will be directed to an appropriate person. And again, I just want to thank Dr. Joseph Karam, Dr. Steve Abbate, Dr. Hanni Salih for being with us this evening. Thank you.
Thank you.
Thank you.